Hello, my name is Pirina Pin, and I'm going to talk about angiotensin-neprilysin inhibition in acute decompensated heart failure. Definition: acute decompensated heart failure is a common and potentially fatal cause of acute respiratory distress. The clinical syndrome is characterized by the development of dyspnea, generally associated with rapid accumulation of fluid without lost interstitials and alveolar space, which is a result of acutely elevated cardiac filling pressures. Acute decompensated heart failure can also present as elevated and dyspnea without pulmonary edema.
Your heart is a muscle that pumps blood around your body. The term heart failure can sound frightening, but it simply means that your heart can't pump blood as well as it should. Heart failure can be caused by a number of things, most commonly a heart attack, high blood pressure, problems with heart valves, or cardiomyopathy, a disease of the heart muscle. Joe has just been diagnosed with heart failure. Because his heart can't pump blood around his body as well as it should, it's causing symptoms in different parts of his body. When blood isn't flowing properly, it can lead to a build-up of fluid or congestion, a bit like a traffic jam. This fluid sometimes builds up in Joe's lungs, leaving him breathless. Fluid can also build up elsewhere in Joe's body. He notices this as weight gain and swelling in his feet, legs, lower back and abdomen. Joe also suffers from fatigue because his heart can't deliver enough oxygen-rich blood to his muscles. With your continued support, we're funding research to one day find a cure for heart failure. Right now, Joe uses medication to manage the symptoms and help him have a good quality of life. Joe has also made some lifestyle changes to help keep his heart healthy, such as quitting smoking, cutting down on alcohol and salt, staying active and keeping a healthy weight. Joe doesn't need any further treatments at the moment, but because heart failure can get worse over time, he may need them in the future. Some people are recommended to have a pacemaker or implantable cardioverter defibrillator, ICD, to help treat their heart failure. Joe spoke to his doctor about the impact his heart failure could have on his driving, getting car and travel insurance, and his work. His doctor has also recommended a cardiac rehabilitation program to help him get back to as full a life as possible. The program has improved Joe's energy and stamina and gave him the emotional support he needed when feeling low. This has helped Joe to continue enjoying life. For more information on living with heart failure, visit bhf.org.uk. BHF. Beat heartbreak from heart failure. Beat heartbreak forever.
Applications in medicine. Ultimate evidence-based treatments remain poorly defined despite the high prevalence of the condition and its associated morbidity and mortality. Despite multiple trials of promising therapies, the standard of care, which consists of the congestion with intravenous diuretics and hemodynamic support with vasodilators and inotropics, have remained largely unchanged during the past 45 years.
Let's talk about the role for the ARNI, right? Sacubitril/valsartan, I guess, is the only one just now, in heart failure with reduced ejection fraction patients. Who are the right candidates for this? Is it everybody, or is it a select subgroup of folks that you'd start?
Well, let's start with what the guidelines tell us to do.
Okay.
So the update to the guidelines that came out in 2016 say that patients who are currently tolerating, who are symptomatic, so functional class 2 and 3, heart failure with reduced ejection fraction, who are tolerating an ACE inhibitor or an ARB, should be switched.
Okay, I want to make that very clear.
Yes.
This is a big, big recommendation.
Yes.
Tolerating should be switched.
Correct.
That's on the basis of really good results on the study we just talked about.
Exactly. A very large study, meaning patients who are symptomatic, who are on an ACE inhibitor or an ARB, who remain symptomatic, should be switched.
Okay, who should not be switched? Let's turn it upside down.
So one of the things that was observed in the trial was about a 10%, correct me if I'm wrong, maybe 11%, symptomatic hypotension with patients who were taking sacubitril/valsartan versus enalapril. So there is a more pronounced blood pressure lowering effect with sacubitril/valsartan. So patients whose blood pressure is already on the lowish side, who may be symptomatic in terms of orthostasis, are not good candidates for switching.
They could fall over. Right? I mean, you don't want to take somebody who's just about on the edge of acceptable blood pressure and make that lower.
Well, it's going to be a little more difficult in those patients.
Okay.
And it doesn't mean that you may not want to try in some, but I think you have to be careful about it.
Okay.
This drug is a potent blood pressure lowering drug.
Yeah, and in addition to what Orly had mentioned, clearly if you have a contraindication, so if you're currently on an ACE inhibitor, clearly there needs to be a 36-hour washout period before initiating Entresto. Other contraindications, if you have angioedema and you had angioedema on an ACE inhibitor, and for some strange reason they switch you over to an ARB and you're fine. I don't care if it's valsartan, it's still contraindicated, and those patients should not be started on Entresto.
Pros. The initiation of sacubitril/valsartan therapy after hemodynamic stabilization led to a greater reduction in the NT-proBNP concentration than enalapril therapy, a difference that was evident by the first week. The sacubitril/valsartan therapy was associated with a lower rate of rehospitalization for heart failure at 8 weeks than enalapril therapy. Cons. Sacubitril/valsartan can cause serious side effects like renal insufficiency, hyperkalemia, several allergic problems, hypotension, and fetal toxicity.
Sacubitril/valsartan can be prescribed in the management of heart failure with reduced ejection fraction. It is a combination of two medicines. Sacubitril, a neprilysin inhibitor, helps with the body's natural process of removing excess fluid. Valsartan, an angiotensin-2 receptor blocker, helps to reduce blood pressure by relaxing your blood vessels and stopping excess water building up in the blood. This makes it easier for your heart to pump blood around the body. If you are taking sacubitril/valsartan, you should not take any other angiotensin-converting enzyme inhibitors or angiotensin-2 receptor blockers at the same time. If you take these medicines together, it increases the risk of developing a life-threatening allergic reaction, angioedema. You may not always be able to tell that your sacubitril/valsartan is working. However, you should notice an improvement in your symptoms after a few weeks. Sacubitril/valsartan is a key medication that helps to reduce the need for you to be admitted to hospital and also helps you live longer. You will normally need to take sacubitril/valsartan to support your heart for the rest of your life.
Issue applied in Ecuador. Heart failure in Ecuador affects approximately 1.4 million people, which represents 14% of the adult population. It's estimated a group of adult population doesn't have a medical support or adequate treatment. Select patients can receive sacubitril/valsartan. Conclusion. In the PILLAR-HF trial among patients with heart failure, reduced ejection fraction who were hospitalized for heart failure, it was demonstrated that initial sacubitril/valsartan therapy led to a greater reduction in NT-proBNP. There were no significant difference between the sacubitril/valsartan group and the enalapril group with regard to the rates of the symptomatic hypotension, renal insufficiency, and angioedema.